am very pleased that you all could join us today. We have an awesome webinar that we're going to do today, and it's part of a 12-week didactic series. Amanda, can you forward the slide for me? Thank you. So this didactic series is geared towards students, trainees, and early career neuropsychologists, and all others who are interested in maintaining their neuropsychological breadth of knowledge while we socially distance in these times. So over the course of 12 weeks, we're going to have 3 month-long series that will focus on different topics each week. So those topics are clinical disorders, professional development issues, practice issues, and research skills. So these 4-week topics will repeat each month with different subtopics underneath those themes. This, can we go to the next slide, please? Thank you. This neuropsychology didactic series was created by trainees and early career neuropsychologists who are part of the Neuropsychology Committee. Our goal is to provide free, high-quality didactic opportunities for the international neuropsychology community. Before we start, there are a few housekeeping things that we need to take care of. If we could advance the slide. First of all, here are the disclaimers for the series. So importantly, this series is not meant to replace or serve as a substitute for formal education in psychology or neuropsychology. And the views of the speakers are their own and do not reflect the official position or endorsement of any institution or organization. So as we have everyone join the call, please ensure that your audio and video is muted so that we can all hear Dr. Gooding's presentation without any interruptions. Questions can be submitted via the chat box option, which you can find at the bottom of your screen. We will address all questions at the end of the talk, so I will ask these questions of Dr. Gooding, and I'll keep a running list of the questions on my side. A recording of today's lecture will be provided later this week via email, and please be sure to check that email for information on how to sign up for the remainder of the 12-week series. All right, advanced slide, please. Thank you. So now it is my pleasure to introduce Dr. Amanda Gooding. Dr. Gooding is a board-certified clinical neuropsychologist and faculty member in the Department of Psychiatry at UC San Diego, where she conducts evaluations for a diverse clinical population spanning traumatic brain injury, stroke, dementia, and other neuropsychiatric disorders. She conducts pre- and post-surgical evaluations for the epilepsy and brain tumor neurosurgery teams at UC San Diego, as well as provides WADA and intraoperative language mapping procedures. Broadly, Dr. Gooding's research is focused on improving post-operative cognitive and functional outcomes in individuals who have had brain surgery. She is also interested in advancing intraoperative brain mapping techniques, as well as investigations related to cross-cultural neuropsychology and the assessment of bilingual and monolingual Spanish speakers. Dr. Gooding supervises trainees of all levels, including practicum students, interns, and postdoctoral fellows. She is the chair of the APA Society for Clinical Neuropsychology, or Division 40, Early Career Neuropsychologist Committee. She is passionate about education-related issues and professional development as it relates to both individuals' needs and the field of neuropsychology more broadly. Alrighty, Dr. Gooding, if you'll take it away.
All right. Thank you, Julia, for that introduction. That was wonderful. I just want to say I'm really happy to be a part of this initiative and to be able to kickstart our didactic series with this talk. I've been working with epilepsy patients for almost 10 years now, and this is really a talk that I love giving. For any of my trainees who might be on the Zoom today, some of these slides may look familiar to you. But hopefully there's some learning for everyone. So just a couple of disclosures. I have no relevant financial disclosures. As mentioned before, I am a committee member for the No Neuropsychology Initiative. So this is an overview of the learning objectives of what I hope to cover in today's talk. I'm going to start out with some basic terminology and definitions regarding epilepsy, as well as some important facts and statistics. We will also cover various etiologies and treatments for epilepsy. And in particular, I'm going to spend a lot of time today talking about the surgical options available for this population. Also, what are the outcomes and predictors of good surgical responses, the role of neuropsychology in the surgical workup for these individuals. And then at the end, I put together a case example that I thought would be a good way to sort of apply this knowledge and see how it has really occurred for a real life patient. And then at the end, I have some additional resources for those who are interested. So first and foremost, why is it important for, in my opinion, all neuropsychologists to have a basic, at least a basic understanding of epilepsy? Well, it's because epilepsy is the third most common neurological disorder in the US after Alzheimer's disease and stroke. As we're going to discuss, it is not a single disorder per se, but actually represents a family of over 40 different syndromes. Seizures are actually relatively frequent and common. So 10% of Americans will have at least one seizure in their lifetime. By age 20, approximately 1% develop epilepsy, and then this continues to increase with time. By age 75, approximately 3% of the population will be diagnosed with epilepsy. So even if this is not your area of specialty or you are not working in an epilepsy surgery clinic, I think there is still a knowledge base here that can help you with your other patients because there are many comorbidities, as we'll see. So the incidence or the probability of developing epilepsy follows a U-shaped distribution with higher rates in children and adolescents, as well as in the elderly, and relatively lower incidence rates in young adulthood and middle age. So as we can see in this graph, this pattern is seen in population samples from both Europe and the United States. We also know that the incidence of epilepsy is greater in African Americans and other socially disadvantaged populations, and males have a slightly increased incidence over females. Approximately 50 to 70% of all epilepsy cases are idiopathic, meaning that we actually do not know the underlying cause of their seizures. There's no identifiable lesion or other abnormality. About 50% of new cases will have a generalized onset, and in a couple of slides, we're going to talk about what that means to have a generalized onset. But it is more common in children under the age of 10. After age 10, more than half of new cases will have partial or focal seizure onsets. So certain clinical populations have an elevated risk of developing epilepsy. In particular, if we're looking at pediatric samples, approximately 10% of children with intellectual disability will have seizures, 10% with cerebral palsy, and approximately 50% of those children that are afflicted by both disabilities. We also see this on the other end of the age spectrum. So in older adults, in particular in Alzheimer's patients, approximately 10% will develop epilepsy, and stroke patients have an even higher incidence of approximately 22%. So some important definitions here. So I'd like to disentangle the word seizure from the word epilepsy. So epilepsy is a disease that is characterized by an enduring predisposition to generate epileptic seizures. A seizure itself is transient signs or symptoms of abnormal, excessive, or synchronous neuronal activity in the brain. So the important piece to this is that a single seizure does not denote epilepsy per se. So how do we define epilepsy? So the International League Against Epilepsy, or the ILAE, is an organization with more than 120 national chapters. And the goals of the ILAE are to advance and disseminate knowledge about epilepsy, to promote research, education, and training, and to improve services and care for patients, especially through prevention, diagnosis, and treatment. And as part of these initiatives, the ILAE has formed various task forces over the years to provide operational definitions of epilepsy and to help with the classification of different seizure disorders. So this publication came out in 2014. This is the most recent clinical definition of epilepsy. And what this publication promotes is that epilepsy is diagnosed when an individual has at least 2 unprovoked or reflex seizures occurring more than 24 hours apart, or an individual can have 1 unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk, okay, or the diagnosis of an epilepsy syndrome. Now, to clarify here, a seizure is considered provoked when there's a transient factor acting on an otherwise normal brain to temporarily lower the seizure threshold. So provoked seizures can be considered as being synonymous with a reactive seizure or an acute symptomatic seizure. So for example, a seizure after a concussion, or in the context of a high fever, or in association with alcohol withdrawal, each would exemplify a situation where it was a seizure that was provoked. So in and of itself, a single provoked seizure would not lead to a diagnosis of epilepsy. Okay, and this paper also specified that epilepsy can be considered resolved if a person either has an age-dependent epilepsy syndrome but are now past the applicable age, or a person has been seizure-free for the last 10 years with no seizure medications for the last 5 years. So a few years later, in 2017, the ILAE again commissioned a group of experts to revise the classification system of seizure types. So we know that there are more than one type of seizure that a person can have. And over the years, the classification system and the terminology that's used has changed. For the purpose of this talk, I'm not going to go through the historical classification systems that were used, but I'm going to talk about what is the current nomenclature, which comes directly from this 2017 article. And in essence, and this table is directly from this article, seizures can be classified as having either a focal onset, a generalized onset, or an unknown onset. When we're talking about a focal onset seizure, this implies that the seizure activity or the epileptic activity is originating in one hemisphere of the brain, or in particular in one focal region of the brain. Okay. And that is in contrast with a generalized onset seizure, where the seizure activity at onset involves the entire brain all at once. Now, within this classification system, we can further stratify our focal onset seizures as having either retained awareness or impaired awareness based on the person's mental status during the seizure. And we can further specify the seizure type based on onset, whether there is a motor onset or a non-motor onset. And for the purpose of this talk, I'm not going to go into a lot of depth about the various seizure semiologies, other than to highlight that the seizure semiology refers to the clinical manifestation or the clinical symptoms of the seizure. So it reflects behavioral symptoms. And it's important for us to consider, particularly in the context of an epilepsy surgery workup, because the semiology or the behavior at the onset of the seizure can often provide clues as to the location of the seizure onset, which might provide a targetable resection area. In this classification system, seizures can also be classified as having focal onset with focal to bilateral tonic-clonic. So this replaces the previous terminology, which was a secondarily generalized seizure. So now we call it a focal to bilateral tonic-clonic seizure. So this is an instance, for example, when a seizure may originate in a focal area of the brain and then spread to involve other areas of cortex as the seizure evolves. And then this last category here is the unknown onset, and generalized. It may be because the individual has not undergone comprehensive workup, or as we're going to see later in this talk, they may have had a very thorough workup, and it's just a bit more complicated and sometimes difficult to tease apart. So epilepsy and seizures can be caused by many, many, many different things. So first and foremost, there are some epilepsy syndromes that have a genetic link. Things like trauma, so anything from a concussion to a TBI to a stroke, can all lead to seizures. Medications or substance use, conversely, withdrawal from medications or substances such as alcohol can produce seizures. Infections, other general medical comorbidities such as electrolyte imbalances, tumors, in particular brain tumors, vascular malformations such as cavernous angiomas, hemangiomas, arteriovenous malformations. And then, of course, we have this whole category of developmental malformations or disorders during the migrational period of neuronal development. And so this is where we can see things like hamartomas, focal cortical dysplasias, heterotopias, polymicrogyria, tuberous sclerosis, etc. So this list is not meant to be exhaustive, but rather to highlight that many different etiologies can contribute to seizures. So in terms of rates of remission, for the majority of individuals that have epilepsy, they can actually achieve seizure freedom on medication. So in fact, approximately 70% can achieve 5 or more years seizure-free on medications. For those who do achieve seizure freedom for that 2 to 5 year window, a large percentage of those patients can actually be withdrawn from the medications over time. But unfortunately, this doesn't capture all patients, and 10% of new epilepsy patients fail to gain control of their seizures, even despite optimal medication management. And these are the individuals that we see in epilepsy surgery centers, such as the one that I work at UC San Diego. So these are really the more complex cases, the more challenging ones. This often tends to be when neuropsychology can be involved. So it's easy to fall into the mindset that all patients have complex ability to gain seizure control. But in fact, actually, if we look at the data, the vast majority of people can do quite well on medications. For those who cannot gain seizure control on meds, unfortunately, it becomes a bit more complicated for certain populations. So for those that have other neurological conditions, such as a prior stroke, for example, intellectual disabilities, cerebral palsy, or other types of comorbidities, those samples also tend to have lower rates of remission. So what are our treatments? So first and foremost, our medications. It's a class of medications that we call anti-epileptic drugs, or AEDs. There are many, many, many of them out there, and we're not going to talk about specifics regarding medications today. But that is the first line treatment for most individuals. However, as we saw in the previous slide, about 10% will not gain control with AEDs alone. And depending on the severity of their seizures in terms of frequency, there are other options that we can consider for treatments. And so these are some of them that we're going to discuss today. So we have something called a vagal nerve stimulator, or a VNS. We have a responsive neurostimulator, or RNS. We have various surgical options, which we will discuss. And then there's also something called a ketogenic diet that works for some patients. It tends to be difficult to maintain. It involves a very high fat and very low carbohydrate diet that requires really strict compliance in order to be effective. So for many people, it's just not a feasible option for them to maintain over time. So let's take a look at some of these other treatments now. So this slide shows what a vagus nerve stimulator is. And so when a patient has this type of device placement, there is a pulse generator here that is implanted in the wall of the chest cavity, and it has electrodes coming off of it that send a electronic pulse via these electrodes that are placed directly on the vagus nerve. Okay, and this pulse is being generated at a continuous rate. It can be adjusted, but this has been effective for some individuals in controlling their seizures. The sort of newer version of this is something called responsive neurostimulation. So with the VNS, as we saw, the device is implanted in the wall of the chest, and it's less invasive than something like an RNS. So as we see here, this RNS device is actually implanted in the skull of an individual, and the electrodes, instead of being placed on the vagus nerve, are actually placed deep within the cerebral hemispheres, originating at the sites where the seizures are thought to be originating from. And rather than generating a pulse in a continuous fashion, these electrodes here are actually designed to detect when a seizure starts and essentially short-circuit it by generating an electrical pulse to stop the seizure. A benefit of RNS is that it allows for 2 seizure targets. So for individuals who may have multifocal seizures, so recall earlier I spoke about focal seizures, it is possible to have multiple focal areas of epileptogenic tissue. And this RNS device does allow for implantation and treatment of 2 potentially seizure foci. So for those patients who are failing to gain control of their seizures, there are various surgical options that we will review. And first I'm going to talk about what the surgical pathway looks like, because there's a lot of monitoring and testing that needs to be done to really identify who's going to be a good candidate for epilepsy surgery. The first step in most cases is for an individual to undergo a phase 1 VEEG. So that's a video EEG. And I'll show you a picture of kind of what this looks like. Importantly, the phase 1 video EEG involves placing electrodes on the scalp of the individual. So it is fairly non-invasive. And a patient is brought into the epilepsy monitoring unit, or the EMU, where they are tapered off of their medications with the goal of hopefully having seizures while being recorded. And so there are 2 types of recordings happening simultaneously. We have the EEG data from the scalp electrodes, and we have video data to actually look at what the clinical semiology is of what their seizures look like. After obtaining some phase 1 data, that will tell us a bit potentially about the lateralization of our seizures. So whether they're coming from the left or the right hemisphere. We may be able to pinpoint a bit further whether they look more frontotemporal, for example, versus more posterior. But this is not a precise indication of where the focal onset might be. So we can use a second type of video EEG. So it's called a phase 2 or sometimes a phase 3 video EEG monitoring. And during this study, it's more invasive, as we'll see, but there are actual depth electrodes that are placed within the brain to allow for a more precise localization recording of seizure activity. We incorporate neuroimaging data, so CT, MRI, PET, depending which centers you work in, MEGs or SPECT, so magnetoencephalograms, or single photon emission computed tomography can be used to also identify seizure foci. There is a neuropsychological evaluation for all pre-surgical patients. And then in some cases, additional sort of special procedures like WADAs, fMRIs, or cortical mapping might also be a piece of the neuropsychological evaluation. So this is a graphic showing just a standard phase 1 video EEG. So again, the electrodes are placed directly on the scalp. It's not invasive. Okay, it's not as precise because you know, we can't measure at the depths or sort of more mesial areas of the brain, but it is a good way of looking at lateralization. So this is an example of a phase 2 monitoring. So phase 2 monitorings are more invasive, as I suggested, and there are 2 different ways this can be done. One is via a grid, such as this, in which a grid of electrodes is placed on the cortical surface of the brain. This is obviously done via a craniotomy and a surgical procedure. I apologize for not giving you guys a little warning about this graphic here. So the individual has to undergo a craniotomy. Once the surface of the brain is exposed, a grid is placed on the cortex itself. Each of these electrodes is able to monitor for seizure activity. And then the skull can actually temporarily be replaced, and the person is brought back to the epilepsy monitoring unit, again, in the hopes that they will have seizures that we can identify electrographically with this data and also via video. Another type of phase 2 monitoring is stereotactic EEG, or depth electrodes, as they're also known. So as we see here in this image, this feature actually allows us to place depth electrodes deep within the brain in order to record from more mesial structures potentially. And in these images, each of these dotted lines represents an electrode. So not only does this allow for monitoring deep at the pointed tip, but also all the way out to the cortical surface. And so when we do this type of study, it is not typically just a couple of electrodes. Depending on the suspected seizure focus, it can be quite extensive. So as you see here, this individual actually has bilateral, both temporal and frontal depth electrodes. And again, these are placed in the OR. It is still an invasive procedure, but it does not involve an open craniotomy. So there are reduced risks there in terms of infection and other. And once these electrodes are placed, again, the person's head is wrapped and they're sent back to the epilepsy monitoring unit where we observe their seizures. So this is an example of what MEG data looks like. So this can help us look at typically interictal epileptiform discharges. In this case, we see it's a very nice tight cluster of spike activity that is recorded typically over about, I believe it's 1 to 2 hours that these studies are conducted. And unless someone actually has a seizure while completing the MEG, this is all interictal data. So this is not a seizure itself, but this is just an area of cortex that is having some discharge activity at baseline. So what are our surgical options? With time, we have advanced significantly, and there's lots of different procedures that can be considered. The sort of most standard procedure that used to be most frequent is the temporal lobectomy, or really any lobectomy. Essentially, this is a craniotomy and a resection of a large area of cortical tissue. A smaller version of this open type of surgery would be a lesionectomy. So if an individual has an identified lesion, such as a brain tumor or a cortical malformation, the surgical target may not necessarily be a whole lobe of the brain per se, but really just targeting that tissue which we have identified as being abnormal. The transpeel or subpeel resection is another surgical treatment that can be used in scenarios where the epileptogenic brain regions, from where the focal seizures are originating, cannot be removed safely. So we don't want to take out that cortex because it's eloquent or it's an area that would cause functional damage to the patient. So the surgeon makes a series of shallow cuts or transections into the brain's cerebral cortex. And these cuts are thought to interrupt some of the fibers that are connecting neighboring parts of the brain, but they don't appear to cause long-term functional impairment in those areas. The cortex remains. It's just a disconnection procedure, essentially. Then we have a corpus callosotomy. This is an operation that severs or cuts the corpus callosum, which interrupts the spread of seizures from one hemisphere to the other. So seizures generally do not completely stop after this type of procedure. They will continue on the side of the brain in which they originate. However, the seizures usually become less severe as they cannot spread to the other opposite side of the brain. And so this may be an option for an individual who may be having very severe seizures, potentially with injuries, if they're not a candidate for other types surgical options. This is what we would consider a palliative procedure. Then we have a functional hemispherectomy, in which one hemisphere of the brain is either partially removed or more frequently disconnected from the other hemisphere, again, to potentially stop the spread of seizures into both sides of the brain. We have laser ablations, or LITS, laser interstitial thermal therapy. So this is a minimally invasive procedure. It does not require a craniotomy or any sort of open resection, but it actually uses a laser to target a circumscribed area of the brain in which that tissue is ablated. It is heated up with the laser and ablated without actually removing anything. And then newer surgical options that have come onto the market more recently, deep brain stimulation, or DBS, which is used for other neuropsychiatric disorders. It's used in Parkinson's disease quite frequently. It's also been FDA approved for use in epilepsy cases. The DBS targets for epilepsy is the anterior nucleus of the thalamus. So not all epilepsy patients are going to be a candidate for this type of procedure, but it is an option for some. What predicts a good surgical outcome? Because before we proceed with any of these procedures, whether we consider them minimally invasive or more invasive, is we want to know who's going to be a good candidate to undergo this type of surgery. Well, we know that individuals that have a unilateral and a very focal onset of their seizures tend to do better. If it's an identifiable target, for example, a lesion such as a brain tumor or a cortical dysplasia, something identifiable that we can see on MRI, that usually predicts a more favorable outcome, as opposed to those patients whose MRI looks essentially normal. That increases the risk a bit for poor surgical outcomes. We want their semiology to be consistent with their EEG. So what this means is the semiology, as I mentioned before, is the clinical manifestation of the seizures. We want that to be consistent with what we would expect it to be based on known patterns of functional neuroanatomy and based on their EEG data. So if the EEG is telling us that the seizures are originating from the left motor strip, for example, we want their semiology to suggest right-sided motor involvement. That would be congruent. When these don't match up, that tends to be a poor prognosis. Those with temporal lobe epilepsy specifically have better outcomes post-surgically. So temporal lobe epilepsy is the most common form of focal onset epilepsy. And this was really kind of the pioneering of epilepsy surgery, was with these patient populations. In a temporal lobectomy, it is typically the anterior 2/3 that are removed, with or without the mesial temporal structures. When individuals have something called mesial temporal sclerosis or hippocampal sclerosis, that's also a favorable outcome because it does suggest an identifiable target of where the seizures might be coming from. And then finally, those individuals who are less cognitively impaired at baseline tend to do better from the surgical perspective. So what is the role of neuropsychology in all of this? I'm sure this is why many of you joined this talk today. And there's a couple of sort of unique pieces to being a neuropsychologist working in an epilepsy surgical center. So first and foremost, we might be called upon to provide baseline and follow-up evaluations for patients, both surgical and non-surgical cases. So, and this varies a bit from center to center. At my center at UCSD, we routinely evaluate all patients with epilepsy, whether or not they're being considered for surgery or not. They all typically receive a referral to see us. Especially those who are being considered for surgery, they must have a baseline neuropsychological evaluation if it's feasible to do so. And in an ideal setting, we also would follow up with these folks after surgery to determine how their functioning is doing post. Now, there's sort of a unique role of neuropsychology in this context, in that we are not just characterizing cognitive functioning, but we play a unique role in helping to lateralize and potentially localize areas of dysfunction that might correlate with the other data we've collected. So we have, for example, MRI evidence and EEG evidence of a left mesial temporal seizure onset. In an ideal world, neuropsychology is going to also really look at those left mesial temporal functions to determine if our data is congruent. Again, I talked a bit earlier about we want our data to match up. We want congruency. And we're going to look at that in a case example coming up in a little bit. And with these evaluations, they are comprehensive and they are lengthy evaluations in most cases. And there is a real huge focus here on evaluating memory and language for these patients, particularly those with temporal lobe epilepsy. So the neuropsychological evaluations and the batteries can vary a bit from center to center, but most will include, as I mentioned, a lot of in-depth testing regarding memory and language. Because we're thinking about lateralizing and localizing dysfunction, we're also going to be very mindful of looking at visual versus verbal to see if there is any sort of lateralized neuropsychological profile regarding their memory or their general cognition. So language versus visuospatial skills, for example. Executive functions are also very important to evaluate in this population. There's quite a bit of data that suggests that even those individuals without frontal lobe seizures can have executive dysfunction. And then, of course, motor is very important because it can be a very strongly lateralizing finding. So intellectual functioning, or IQ, this question comes up a lot with patients and their families, particularly when someone is newly diagnosed with epilepsy. In general, epilepsy is not associated with intellectual decline per se. There can be cognitive impairments that are related to seizures, and we're going to talk about what some of those are. But in general, IQ is not something that declines with an epilepsy diagnosis. Now, there are, of course, exceptions to this, particularly some of the genetic and neurodevelopmental disorders and comorbidities. So when we see intellectual disability, it tends to co-occur with other diagnoses. So the person may have epilepsy, but they also have, for example, intellectual disability, autism, or cerebral palsy. So what are some of the factors that can affect cognition? So AED toxicity is an important consideration. Different medications have different cognitive profiles. Some have more severe impacts on cognition than others. So it's very important to know your anti-epileptic drugs if you're going to do this type of work. And similarly, to think about not just which medications they're on, but which combinations of medications. Oftentimes, for this 10% of folks that are not gaining good seizure control on medications alone, they're frequently on 2, 3, 4, sometimes even 5 anti-epileptic drugs. We tend to see as the number of medications increases, so does the likelihood that they may have some cognitive side effects. The etiology of their seizures is really important to consider in thinking about someone's cognition. If someone has an essentially normal MRI and there is not an identifiable etiology, they may have fewer cognitive impairments, for example, than someone who had a massive left hemisphere stroke. Okay, and so then we get into a situation where we have to think about how is their cognition being affected by the stroke versus by the seizures themselves. The same is true of brain tumors, vascular malformations, etc. So thinking about the etiology is a really important consideration when looking at their cognitive profile. Those that have early onset seizures and those that have poor seizure control, meaning that they're having frequent seizures, those individuals tend to have worse cognition as a whole. I know these are kind of sweeping generalizations, but my goal here is really to give you guys a big picture. And then, of course, surgery is something that can affect cognition. Many times, as we're going to see with my case example, it's not always a clear-cut single surgery. Sometimes individuals may undergo multiple procedures, each one of which can affect cognition independently. So as neuropsychologists, our goal with these evaluations is not just to focus on the cognitive sequelae of a person's seizures, but also looking at other neuropsychiatric contributions to their profile and other considerations that need to be had when considering having epilepsy surgery. So unfortunately, individuals with epilepsy have higher rates of depression and suicide than the general population. There are higher rates of general psychiatric disturbances and other risks for negative consequences down the line, both related to neuropsychological variables and potentially also psychosocial and family variables. And so this is something that is really important not to overlook in the context of a surgical workup, is thinking about someone's psychosocial situation and their readiness to undergo not just invasive workup and monitoring, but also potentially an invasive procedure. Adjustment and quality of life is another really important consideration with this population. So because people are having seizures, they may not be able to drive, okay, for obvious safety risks. And in fact, in some states, a neurologist or physician is required to report them to the DMV to take away their license if they've had seizures before. And so I want you to think about, for those of you that maybe don't live in, urban city centers, think about how difficult your life would be if someone took away your car and you did not have access to transportation. That impacts many areas of your life. It impacts your social life. It impacts your ability to attend school. It impacts your ability to drive yourself to work. And then similarly, if you're having frequent seizures, that may be a really negative impact on your learning, on your work productivity, etc. And then of course, social isolation and the impact that seizures can have on someone's personal life is really significant. And so I caution you guys to really not overlook these variables in your evaluations, because it's a really important consideration in terms of how you're going to make recommendations, but also how you're going to approach a case with your team. So if you are with your epilepsy team discussing whether or not someone should have surgery, these considerations can really sway you in one direction or the other. Then there are some special procedures, I call them special, that neuropsychologists who work with epilepsy teams can be involved in. The first is which is called a WADA. And in a WADA procedure, the goal is to determine language laterality and memory support. Okay, and so what we do during a WADA procedure in brief is we are going to anesthetize one hemisphere of the brain. So we're putting one hemisphere to sleep in order to do some testing with the other hemisphere to see what it's capable of doing on its own. This essentially gives us kind of rough idea of what would happen if we were to surgically remove that hemisphere, noting that we're often not going to remove a whole hemisphere per se, but if we want to know kind of grossly where is language on the left or the right, this WADA procedure can be really helpful. So we anesthetize half of the brain, and we test language and memory. And this is done via different procedures at different centers. I've worked in 3 different epilepsy centers, and we each had a different protocol. Sometimes even different anesthetic agents can be used, something called Amytal, for example, versus something called Brevital. Not important to get into those specifics at the moment, but the goal here again is really to look at what is the ipsilateral and contralateral language and memory support like. This is done in conjunction with the interventional radiology team. So it is a highly coordinated procedure where there's a neurologist involved, a neuropsychologist, the interventional radiologist, sometimes a neurosurgeon. So it is an invasive procedure and not something to be taken lightly. There are some alternatives to WADAs, so fMRIs, MEGs in pets have also been used to look at language laterality. There are some good paradigms for language. I think it becomes a little bit more challenging to look at memory with some of these alternatives. And again, some of this is really center specific. So some centers rely really heavily on the WADA, whereas others exclusively use fMRI. So this will vary quite a bit. But again, the goal here is the same. It's to help the team with treatment planning beforehand. And then neuropsychologists can also be involved in something called language mapping. And language mapping, the goals here is to preserve functioning and in particular protect the eloquent cortex, typically language, prior to or during a resection. And so a neuropsychologist might be called upon to assist the surgical team in determining the most appropriate margins for a proposed surgical cavity so that we can maximize the success of the resection while minimizing functional deficits. Now, language can be mapped via a couple of different techniques. The gold standard for this is direct cortical stimulation, and I will show you a couple of slides coming up next about what this looks like. They are a little bit graphic for those of you who might be a little queasy, so you may just want to come back in a couple of minutes. But also kind of less invasive. There are some, again, paradigms via fMRI for language mapping. And then some individuals, particularly in Europe, I don't see it quite as often here in the United States, but transcranial magnetic stimulation is also being used as a more minimally invasive way of mapping language prior to a resection. And importantly, with direct cortical stimulation, this can be done either intraoperatively during the surgery, or this can be done extraoperatively on the epilepsy monitoring unit. And I'll show you what I mean in just a moment. So this is a patient of ours who was going to undergo language mapping. And so I just included this because I thought it might be interesting for those of you who have never been in the operating room to get a sense of sort of what this setup looks like. And so this is the halo, and these are pins going directly into the person's skull. And the goal here is we need to stabilize the person's head so that they are not moving during the procedure for obvious reasons. So the first step is in any of these surgical techniques or in mapping is we have to remove the scalp. Okay, so this is an image here of this individual's scalp pulled back, so we can still actually see bone here. And then here is where the actual craniotomy is. So this is the piece of the skull that is either being removed or has been removed. I can't quite tell from this image. And then once the bone flap has been removed and the dura has been pulled back, we actually have the brain surface here. So I showed you that image earlier of a grid of electrodes placed on the brain. And in that case, I was directly referring to using those electrodes to monitor and detect seizure activity. In cortical mapping, we use a similar or same type of grid here, but instead of recording seizures, we're actually stimulating the cortex underneath each of these electrodes. So what we do is we can provide a small electrical current into this electrode, which will then disrupt tissue functioning directly adjacent to it and underneath it here. And so what we can do is if this grid is placed on a language area and we stimulate this electrode and the person fails to produce a name on a picture naming task, that gives us suspicion that that cortex surrounding that electrode may be what we call eloquent cortex, or something that we would not want to remove in a potential resection. So this is an example of a grid that's put in during surgery for mapping. And as I mentioned before, for the phase 2 grids, we can actually put the scalp back on and send the person back to the monitoring unit. And so we can also map language from the unit. This doesn't have to be done intraoperatively. It can also be done on the monitoring unit. Okay, so these are some of the ways that neuropsychology is involved with these cases. And I thought what might be nice to kind of bring this all together is to actually go through a case example with you of a real life patient that came through our center not long ago. And he had a very extensive workup, which is why I selected this case to present. So when this gentleman came to us, he was 18 years old. He's a right-handed Caucasian male with 10 years of education. He started having seizures only 2 years prior to coming to our center. So at age 16, he started having seizures. And unfortunately, when he experienced seizures, they would cluster. So it wasn't that he was having them every day, but every 2 to 3 weeks, he would have these clusters of seizures. And unfortunately, in the context of his seizures, he's had a lot of problems arise. So at 16, early on after he was diagnosed with epilepsy, he actually fell during a seizure and broke multiple vertebrae in his back. A few years later, he experienced an episode of status epilepticus. And I did not include a slide on this, but I'll just briefly tell you guys what this is. So status epilepticus is a medical emergency. So it's when a seizure either goes on for more than 5 minutes without stopping, or when a person has repeated seizures, one right after the other without returning to their baseline. That's considered status. And this is a medical emergency. This can be life-threatening. And oftentimes people come into the emergency room in status. And it's dangerous for their brain to be in a prolonged period of seizure activity. And so he had an episode of status, but perhaps, even more importantly, and this is why I encourage you all to think about the quality of life and the adjustment concerns with your patients, is after he would have seizures, he had significant postictal aggression and confusion. He would get into fights, and he has no recollection of this because he's in the postictal state. And this has caused a lot of conflict with family, friends, coworkers. Really, this piece here was really what he and his family described as the most bothersome aspect of his seizures. He was on 4 anti-epileptic drugs, well, 3 plus Ativan, which can also be used PRN to help control seizures or stop seizures. And he'd failed 3 other AEDs previously. In addition, he had comorbid depression, anxiety. He reported suicidality and significant mood lability, a lot of which he attributed all to his seizures and the negative impact on his quality of life. So this was his brain MRI. So I'm going to walk you now through his workup with us. And so we are in an axial T2 flare image here. And if we're looking specifically, I want you to take a look at these mesial structures here, okay? And in particular, the lateral horn of the ventricle on the right hemisphere versus the left. So we see that there's an asymmetry here. And we see it again on another slice right here. Okay, so this hippocampus is much brighter on the left, and there's clearly more ventricular space around it, which raises suspicion potentially for mesial temporal sclerosis. This is the coronal image of this gentleman's brain. And again, if we're focusing right here on these mesial structures, these are the hippocampi. On the right side here, it's nice and plump. On the left, it's kind of shriveled up and small. So this is asymmetric. So this suggests that this hippocampal tissue is not normal and is sclerotic. And here's just another slice here so you can see that. Now, his PET scan did not line up with his MRI. So his PET was reading as having right anterior temporal hypometabolism here. Okay, they did not note any abnormalities in the left mesial hippocampal region, which is where we originally had suspicion. So we have a little bit of discordant data at this point in time. His phase 1 video EEG, so this is via scalp recording, captured 10 clinical events or 10 seizures. Okay, 5 of them were auras and 5 were seizures. And those 5 seizures all had rhythmic theta activity in the left temporal region. And so this was making us think, okay, this is looking kind of like the MRI. We're seeing left temporal abnormalities on both EEG and MRI. He went on to have a phase 2 study where we put in 8 depth electrodes or stereo EEGs. They were placed bilaterally in the amygdala, the hippocampi, and in the insula. So this is what his stereo EEG electrodes look like. So we can see them coming in bilaterally here. And this is just artifact that you're seeing because these electrodes have metal on them. So after those electrodes were placed, he spent a total of 16 days on our epilepsy monitoring unit. So quite a long time, actually. And he had about 100 clinical events per day. So most of those were subclinical electrographic seizures. So what that means is electrographically, the EEG was picking up a seizure, but we didn't actually have any clinical symptoms. There was no obvious semiology per se. Of those, 100 events per day for 16 days, he only had one definite clinical seizure. And all of this kind of data together suggested seizure onset in the left mesial temporal region. Okay, so early onset in the left amygdala and the head of the left hippocampus. So again, all of our data is looking very concordant. He had a baseline neuropsychological evaluation, and I just abbreviated the results for you here. But we see overall, to my point earlier, he has normal intellectual functioning. His memory was impaired for both verbal and visual material, but it was significantly more impaired for verbal. Okay, the scores were much lower, which again would speak potentially to that left MTS that we saw. He also had some impaired language scores, but not all. So he had impaired letter and category fluency, but his naming was actually low average. Mild to moderate impairments in executive functioning. Overall, the rest of his profile was not strongly lateralizing, but his evaluation was notable for severe anxiety. He underwent a WADA procedure, which showed a very clear left hemisphere language dominance. When we looked at his memory scores, they suggested roughly greater left greater than right hemisphere memory support. So even the baseline neuropsychological data showed us that his verbal memory was quite poor. Actually, his verbal memory, or his memory, I should say, is better on the left than the right. This isn't a huge discrepancy, 9 percentage points. And again, depending where you work, different centers look at WADA data a bit differently. At my center, we use a discrimination index. But other centers use things like accuracy. So we ultimately, as an epilepsy team, came to a consensus decision that he should undergo a laser ablation of the left mesial temporal lobe. So if you recall, a laser ablation is a more minimally invasive procedure. So since we had really thought that the amygdala and hippocampus was the seizure focus, we thought that he would be a good candidate for the ablation. So he underwent that procedure, and initially he did quite well. He had no seizures, he had fewer auras. Overall, he was reporting higher levels of quality of life. But about 4 months afterwards, the seizures recurred. And so he came back through our center for more workup, and we decided to re-ablate that same site. So sometimes there are instances when a laser ablation needs to be repeated to ensure that the tissue is actually adequately destroyed. And he really didn't get any benefit. He was still having a seizure cluster every month. And actually, he and his mother were reporting increased anxiety and post-ictal aggression. So 2 of the things that were really problematic for him before were actually worse now. And he was becoming increasingly depressed regarding his health status. I just want to show you what it looks like after a laser ablation. So if we look here, this is where the left amygdala and hippocampus used to be. So it has been ablated. This scan is, I think it's about 2 years after the initial ablation. And we can see that this tissue is just gone here, but all of the more lateral cortical tissue is spared. So this is the benefit of doing a laser ablation, is that you don't have to actually cut through this tissue and do an open craniotomy. Again, just looking now at a coronal slice, we see ablation looks successful. That tissue is no longer there. yet he's still having seizures. So we started this process all over again. So unfortunately, when cases like this come up, we have to really sort of go back to square one and repeat the workup. So he had repeat scalp phase 1 EEGs twice. The first time they didn't capture any seizures. The next time he came in, they did capture left temporal seizures. So this tells us that we were in the ballpark of where his seizure focus was, but unfortunately, there is some remaining tissue that continues to be epileptogenic. He had a repeat neuropsych evaluation, and then he had a repeat phase 2. So we did more depths, and in addition to the stereo EEG, we also added some grids and some strips. So he had a pretty extensive phase 2 monitoring. And I believe I have some photos that I'm going to show for you guys. So he had a left frontotemporal parietal craniotomy. We put in grids, strips. He had bilateral stereo EEG, which covered the left hippocampus, the orbitofrontal, cingulate, and the insulate regions. And what we found from his phase 2 results is that actually he was having bilateral independent mesial temporal seizures. This is very unfortunate because with all of our prior monitoring, we only detected the left temporal lobe seizures. But what we found out from this study is that he actually was having bilateral, meaning both hemispheres, independent, meaning this is not a focal seizure that spreads to another area, but actually 2 separate areas of focal tissue where seizures are originating, so in both hemispheres. And then additionally, we found that he had some interictal irritability in the left lateral temporal region. And actually there was an area where they suspected that he had another seizure focus in the left posterior lateral temporal lobe, so right around the area of Wernicke's. And if you recall, his WADA told us that his language was in the left hemisphere. So this is really concerning because now we're seeing multifocal regions in both the mesial areas, potentially the lateral areas, in both sides of the brain. Ultimately, he and his family elected to undergo a palliative third surgery. So remember, his first 2 were both laser ablations. With this phase 2 study, because he'd had the craniotomy for the grids that were placed on the cortex, he already had the craniotomy. So actually, when they went in and took out the electrodes, he went straight to surgery that day. They did it at the same time. They did a selective amygdalohippocampectomy. So they removed the amygdala, or what was left essentially of the amygdala and the hippocampus on the left side, as well as kind of a standard anterior temporal lobectomy on the left. So as I mentioned before, we do typically the anterior 2/3. As we start going more posterior, that's where we get concerned for things like Wernicke's area and other functional consequences. So he had this more aggressive surgery with the understanding it would be palliative because he had these multifocal regions of seizure activity. He did well for a couple of weeks, and then I actually just was reviewing his chart this weekend, and he had a breakthrough seizure, just a single seizure. It was not a cluster, in the context of a febrile illness. So he had been sick with a high fever for a couple of days and had a breakthrough seizure. So it is to be determined as to his long-term prognosis. And I selected this case not because I wanted to depress you all, but to show you just how complex the decision-making becomes with these types of patients. And neuropsychology really does play a critical role here. So in epilepsy surgical centers, there are weekly or monthly case conferences where we review our data for patients, and we review all of this data just like I did with you. We go through the EEG, we go through the imaging, the neuropsych, and at least in my center, the neurologist will go around the room and make us vote. What do we want? What type of surgery? What type of plan do we propose? And neuropsychology is not exempt from that. in fact, in this case, we were pretty critical in the decision-making, given that we needed to be very mindful of maintaining this young man's quality of life, preserving his language, and really trying to make this a better situation, not a worse situation. So I find it a incredibly rewarding team to work with, incredibly rewarding opportunity to work with these types of patients. But as you can see from this presentation, it is pretty complex at times. And you have to have a good understanding of these, the workup that's involved prior to surgery. So for those of you that are interested in learning more about the role of neuropsychology in epilepsy, I could speak about this for weeks on end. So trying to fit this all into one talk is a little challenging. But for those of you that are interested, there's a couple of great resources out there, and I'll just note, I receive no royalties from any of these. But these two textbooks, the Neuropsychology of Epilepsy and Epilepsy Surgery, and the Handbook on the Neuropsychology of Epilepsy, are both great resources. I already mentioned earlier the International League Against Epilepsy, tons of great position papers and educational resources on there. They also put out this publication recently. This is hot off the press, a ILAE report about essentially the role of neuropsychology in epilepsy surgery. Great article. And then the Epilepsy Foundation, also similar to ILAE, provides some really great resources to educate yourself, also for your patients. I frequently tell patients to check out the Epilepsy Foundation resources. Things like support groups and other resources for families can be really helpful. So with that, I thank you all for this opportunity, and it was great speaking with you, and I'd be happy to take questions.
Alrighty, thank you, Dr. Gooding, for that presentation. We do have quite a few questions, so we're going to see if we can get through a decent majority of them in the time that we have left. The first questions I think we should start with will be related to the case example, since it's still fresh in our minds. First of all, do you usually prescribe a program of post-surgery rehab, and if so, what for this type of patient?
That's a really great question. So there's actually not a lot of data on cognitive rehabilitation in post-surgical epilepsy patients. Most of the cog rehab data that we have is looking, for example, at disorders of aging, such as MCI and Alzheimer's disease. So to my knowledge, there is not a protocol that really was developed specifically for epilepsy per se. But that said, it's really on a case-by-case basis. So sometimes after surgery, when there are unfortunate consequences, patients will need speech and language services, PT, OT, speech therapy, those types of referrals can be made. I do sometimes a bit of education with my patients about compensatory strategies for potential cognitive impairments, but there's not really a lot out there right now specifically about rehab in this group. I think it's certainly something that would be warranted, though.
Thank you. Other questions related to the case is this outcome common, and what are the consequences of the extent of the surgery that he received?
Yeah, so, this outcome I would not say is common. This is definitely one of the more complex cases that we've had in our center since I've been there over the past 3 years. As you saw looking at those dates, he began with us in 2017. So this has been quite a lengthy process for him. That's not the norm. I would say most cases we, hopefully get it right the first time and don't have to sort of repeat things. But, because his case was a bit more complex, that's the case, unfortunately. But it's quite variable. And the other piece that I will add to that too is, this is just one example of a surgical case. And again, thinking of the data, only 10% of people actually fail to get seizure control without medications. So the vast majority of people with epilepsy do quite well on AEDs. and don't require, this level of intervention per se. It really is a minority of the patients.
All right. So moving on, we got quite a few questions related to assessment, specifically WADA testing. So there's one question that says, from the medical centers I've trained at, WADA procedures have become increasingly rare as imaging alternatives are preferred for their low risk. When is testing preferred, WADA testing?
Yeah, so some of that really just comes down to the preference of the center and the preference of the clinicians, to be quite frank. So when we think about a WADA procedure, it's a disruptive technique, meaning that we are actually disrupting functioning, which gives us a really nice mimic of what would happen if we were to remove that area of the brain. In contrast with things like fMRI, it's an activation technique. And so we're inferring that that is an area that controls the function, but we're not actually disrupting it. So there's sort of a theoretical difference between the two models. Again, there's no right or wrong on this. A lot of it just comes down to centers' familiarity. At UCSD, we don't use fMRI clinically. There's a lot of research with it, but clinically, we're still using the WADA as the gold standard. The other piece to consider is that fMRI has some really good paradigms for identifying language. At least to me, it's less clear which memory paradigms can be helpful in looking at contralateral versus ipsilateral memory support. But I admittedly am less familiar with fMRI because the centers I've worked in have not used it quite as much.
Okay, so speaking of language, we got a few questions about bilingualism in this context. First question is the process of language laterality assessment different when dealing with a bilingual patient? Are there any specific considerations or recommendations for assessment with ethnic linguistic populations or different outcomes from intervention based on cultural factors?
So that's a great question. So I'll tackle the first piece of that first. Ideally, in an ideal world, we would conduct the neuropsych evaluation and the WADA and the language mapping in the person's native language. Sometimes that's possible and sometimes that's not. It depends on the availability of bilingual clinicians in your center. So what I would say is it's important to take into consideration potential test confounds on the sort of baseline neuropsych side. In the WADAs, at least the ones that I've been involved in, it does tend to be more clear-cut in terms of language preservation or not. It's, we have not tested people in both languages. We usually just picked one. And it comes down to availability of, bilingual clinicians versus not. I think I'm getting a little off track from the question there. I would say, again, with your neuropsych evaluations, it's really important to think about the limitations there. With the WADAs and the mapping, it really comes down to just practical resources and what can you do for the patient. Oftentimes it's not ideal. Ideal would be to do it in someone's native language.
Thank you for that answer. Next question is about how long after surgery should a post-neuropsych eval be conducted?
So there's no hard and fast rule for this. If we think about the trajectories of brain recovery in general after traumatic brain injuries of any kind, whether that be induced, like in a surgery, versus accidental, like via a car accident, for example, we see that the period of the greatest cognitive recovery is within that first 6 months. And we can see kind of continued spontaneous recovery for up to 1 year. So for that reason, I have always selected 1 year as the time frame to conduct the post-op evaluation. But there have been cases where we've done it as early as 9 months. It really is case specific. But I would say if we're thinking about the period of cerebral vulnerability and recovery, we'd probably want to wait about 9 to 12 months.
All right, next question. In cases where neuropsych assessment data and imaging data are incongruent, what might be the next step for treatment decision making?
Yeah, and you know, that actually comes up quite a bit. So cognition is not always as clean and clear cut as we would like it to be. And so there are cases when my neuropsych data does not line up with the other findings. And essentially it just becomes a discussion with the team during our case conferences and weighing the relative um, strengths of each piece of data. So how confident are we in that MRI? How confident are we in the neuropsych? And so it really is a discussion in weighing sort of the confidence level that you have for each piece of data, and also the risk-benefit calculation, and thinking about kind of how risky is it to discount one piece of information or prioritize one piece of information over another.
Okay. Regarding psychogenic or pseudo seizures, we got a number of questions regarding assessment, and do these seizures appear different on assessment, and how is or what is the role of a neuropsychologist in differential at this stage, or how do you rule out a psychogenic seizure?
Okay, so to definitively identify a seizure as being psychogenic or not, we need to have the person hooked up to a video EEG at the time of the event. So in the case where, for example, someone is on the unit for a phase 1 monitoring and they have a clinical seizure, so meaning we see behavioral change that suggests a seizure, but there's no electrographic change on the EEG, that would raise suspicion for an instance where it may not be an electrographic seizure. Now, keeping in mind, however, that the scalp electrodes are imprecise and your EEG is only as good as the location that you put those leads. So if someone has a very deep seizure focus, we may not actually detect it as precisely on a scalp EEG. But really, to definitively rule out a seizure as being epileptic or not, it would hinge on whether there's actually an electrographic change that's been identified in the brain. But there are other pieces of evidence that you can look at as well. So you want to think about the congruence between their behavior and known patterns of seizure semiologies. So we have known patterns of brain functioning, and if a seizure is just kind of not fitting what we might know about focal versus generalized seizures, that could potentially raise suspicion. What's important to keep in mind, though, and I don't know the actual percentages offhand, but there is a pretty sizable proportion of patients with epilepsy that experience both. So they may experience genuine epileptic seizures, and they may also experience psychogenic non-epileptic seizures. In those cases, it becomes really important in the setting of a surgical center to make sure you're clear with the team and with the patients about which seizures are which, because you may actually be able to offer someone a curative epilepsy surgery that would cure their epileptic seizures, but they may still experience the psychogenic non-epileptic seizures. And so really thinking about kind of what impact is that going to have on their quality of life. If the ratio is 10 epileptic seizures to 1 psychogenic, I would vote in favor of, yeah, we could consider surgery with this person. If it's flipped and it's 10 psychogenic seizures and 1 epileptic seizure, I would be a bit more cautious in proceeding with any form of invasive procedure. And so, it's not just the role of the neuropsychologist per se. This is the whole team working together to make this decision. But I do see that, our team members call on us sometimes to help with educating patients about PNES, potentially providing them resources for therapy and other avenues to address other underlying emotional stressors. So there was a lot in that answer. Hopefully I covered the questions.
Yeah, that was perfect. Thank you. Just a few more questions. So regarding different types of etiology, this question says, you mentioned cortical spread of seizures. Are there subcortical types as well?
Um, yeah, so the seizure themselves is going to come from cortex, but it can spread through subcortical regions. So it just depends on sort of which structures are involved.
Okay, and
But
then,
But
oh,
if we're thinking about kind of cortical tissue as being the bodies of the neurons, that's where the seizure activity is originating. But it is spread through the axons, which may be more part of the subcortical pathways per se.
all right. Regarding brain tumors that can cause seizures, are there specific types of brain tumors that cause these seizures?
Any type can be an irritant to the brain. When brain tumors tend to grow in size and occupy larger regions of space in the brain, we can have increased cerebral pressure and edema, and that can contribute to the seizures. So it may not be the tumor itself that is epileptogenic, but it's actually the negative impact that it's having on the healthy tissue around it, kind of the pressure that can be exerted. So I would say, to my knowledge, I couldn't name specific types of brain tumors that are more likely than others to cause seizures. But it really just depends on location and size and other factors involved.
Okay. Um, for interventions, are there any age restrictions? This is a question we got a few times. Age restrictions for vagus nerve stimulator procedures or for conducting surgeries?
To my knowledge, there are no hard and fast age restrictions. But at both ends of the age spectrum, both young children and older adults, it does become more of a discussion as to the potential role that age might play. I can say anecdotally, in our center, we have had patients, I think we had someone actually in her 70s that did undergo a laser ablation. And so age was not a rule out for that case. But it is a consideration. For example, with the patient that I'm thinking of, we opted to not do an open resection for her because of her age. And so that's why she was a candidate for more minimally invasive procedures. So age does come into the discussion, but I don't think there's hard and fast cutoffs per se.
Um, are there any concerns regarding placing depth electrodes with damaging tissues or possibly producing a subsequent seizure?
So my understanding is that the placement of the depth electrodes is pretty safe from that perspective. Now, because it's still an invasive procedure, and so there are risks. So the big one being bleeding. So, surgically, any type of surgical procedure comes with potential risks. It definitely does not happen frequently, but we have had a patient where depth electrodes were placed and then she subsequently had a subdural hematoma and a deep bleed. Fortunately, there were not cognitive consequences associated with it. So it is a risk. There, to my knowledge, is no big data looking at electrode placements themselves on impacting cognitive functioning. For example, if we stick electrodes on the hippocampi, I don't know of any data that shows that that disrupts functioning in and of itself, so long as there is not an adverse event like a bleed.
Okay. Another question regarding alternate therapies. Outside of typical AEDs and surgical interventions, what can we say about the utility of cannabidiol or CBD for folks with intractable seizures?
Yes. So there is recently just came out that CBD is approved for a certain types of seizures. I couldn't tell you offhand what that is, but there's actually very clear guidelines as to who's an appropriate candidate for that than others. I believe the Epilepsy Foundation and ILAE both include information about that on their website, but there are some pretty clear consensus guidelines as to who would benefit from that. And it's not sort of a universal all patients with epilepsy per se.
All right, last question. Are there circumstances when results from neuropsych testing might deter a neurosurgery team from proceeding with a surgery?
Yes, absolutely. So in the event, for example, if someone has very poor contralateral memory support on a WADA exam, that might deter us from taking out the healthy hippocampus. Even if that hippocampus is involved in propagating seizures, if we think there's a risk of making someone amnestic or a risk of someone losing language, then 100% that would preclude them being able to proceed with surgery. In the example I gave for the patient I reviewed, that's actually why he had a palliative surgery and not a curative surgery in the end, because one of his seizure foci was near Wernicke's area. And from a neuropsychological perspective, based on our WADA findings, that just wouldn't be a feasible option for him.
Awesome. There were a lot more questions, but unfortunately we just don't have time to get through all of them, but we tried to sort them into categories and then pick the ones that made the most sense across the categories. So thank you all for submitting your questions. Obviously, if there are any follow-up questions, you can get in touch with us via email. I want to go ahead and thank everyone who joined us today, as well as Dr. Gooding for her wonderful presentation. And again, be on the lookout for an email with the recording of today's webinar, as well as information on how to ensure that you're signed up for the remainder of the webinar series. And with that, thank you all so much.
Wonderful. Well, thank you.